started. Jessica, I see that you've logged in. Welcome. So folks, my name is Kim Taylor. I am your current chair of the Regional Behavioral Health Advisory Board. We do have a quorum. I know folks are still joining, so I will attempt to acknowledge folks as they do. Let's go ahead and do roll call for our first meeting of this 2026 year. Again, I have noted some folks as already being here, but I will still call you out. So Michael Lenslie, Shane, I know you are here. How about Amanda Randall? Okay. Gail, I know you are here, I believe, correct? Yep, there you are. Jackie, I know you are here. Jamie Rostick is excused for today. How about Karina?
Yes, I'm here.
Okay, perfect. Lita, you are here.
Yes, present.
Michael, you are here. And then how about Kenny? Okay. I will come back around for those folks just to see if they logged in late. And then other folks that we have, Arlie is here, Ashley, Jessica is here. Let's see. Katerina is here. Is there anyone else from the county that I'm missing? Is Justin will be here at some point or not so much?
Not today.
Not today. Okay. Got it. I also see that Tom is here and Chantel is here. And then Tony from the MCOs is here. How about Liz or Kathleen from OBHA?
I am here from Community Health Plan of Washington.
Oh, perfect. Oh, Liz, I did say your name earlier. I apologize. Yes, I do see that you're here. Kathleen, at all?
Kayleen is not here today.
Or Kayleen, excuse me. Okay.
No, that's
all
okay.
right. All right, let me go back around one more time, just very quickly. Amanda, Kenny. Okay, let's go ahead and get started. Again, thank you all for coming today. I believe we do have a new board member. I understand that she is a little under the weather and her voice is gone. I'm not seeing her present at the moment, but if she should come on, I will introduce her, or at least attempt to. Her name is Renisi. I believe she goes by Nisi. Let me get her last name here, Jones. Looks like she is a certified peer counselor and has a lot of great experience in some other things connected to behavioral health as well. So if she should log on today, she may not be able to speak or introduce herself, but hopefully she can make a couple of comments in the chat, if you will. So I'm going to conclude that everyone's had a chance to look at the meeting minutes from last month since we got them a couple of weeks ago or so. So if there are any edits or changes that are needed, I would like to hear those now. And if not, if we could get a motion to approve in a second, that would be fantastic.
I motion to approve those minutes, Kim.
Thank you, Shane.
I will second.
Perfect. Thank you, Michael. All right, let's move on. OBHA update and mental health directives. Gail.
Okay, thank you. Arlia, if you could make me host or co-host, I have a PowerPoint to share.
When I stop sharing, you're able to share, Gail.
All right, thank you. So today I'm just going to provide an overview of a mental health advanced directive work group that I was privileged to be a part of over the course of 2025, and some recommendations that we had. And also that I'm going to just show you the current form that's being used by the state, which I think it's a good form and it's simple to use. And I'll just briefly let you look at that. And any questions about what a mental health advanced directive is, it really can be a wonderful tool. So let me just get started. And PowerPoints are not my forte. Let's just say that. So anyway,
Disclaimer noted.
yeah. Thank you. And no, not that. Stop sharing. Okay, let me get to my actual PowerPoint. There we go. Okay, now hopefully it'll let me share. There we go. And slideshow. Okay, so this is all a result of second substitute Senate Bill 5660, which a number of us had been working on for a couple of years to push through. We have been meeting as a group way prior to this. I mean, I remember meeting with this group while I was still working at the BHASO. This is all about our collective efforts to make the use and knowledge about mental health advanced directives so more mainstream that it becomes just as easily looked at and thought of as a healthcare advanced directive. So, this was passed in 2024, and it designated that a work group would convene. And this is what it basically said. So I borrowed from a couple of different documents to put this together. So I just wanted to let you know that, so this is what it basically said. It directed the healthcare authority to convene a work group to develop recommendations for the effective implementation of a mental health advanced directives. And this is major work. So we were directed, or the work group was directed to do the following, and there were two subgroups that were identified. So the document storage subgroup was formed to recommend a reliable and standardized and accessible method for mental health advanced directive document creation, storage, and sharing. This is one of the biggest pieces of when a person has a mental health advanced directive, that it's not available. It's you don't have a copy, which most people don't walk around with a copy of it. Or if you haven't been able to have it scanned into your clinical records somewhere that could be accessed, for example, by MyChart or another kind of healthcare record, then it's not going to be available to be seen unless somebody brings a copy with them if they go to the hospital or the crisis, or somebody brings it later. So that was one place where to keep it. And then the second subgroup that I was a part of, and I'll be talking most about, was the training for document creation and utilization subgroup. So this was in order to be able to provide a way for people who would like to have, or would like to have a mental health advanced directive, and for agencies, for family members, for loved ones to know what they are and to be able to support that. So we had some goals. And so again, I'm talking about the training subgroup. And so our goals were identified as making sure that we had partner engagement on topics of document creation, including engagement with persons with lived experience, mental health and physical health providers, and crisis responders. Crisis responders, the inclusion of them, or the thought of having them being able to access certain parts of the mental health advanced directive, or even all of it, was looked at as important because of when a crisis is actually happening. So the other part that we did was we developed the development of training toolkits that was in best practice for recovery and peer support. Designation of a hosting location, so that was like wherever it would be. And development of recommended best practices for creation and completion, access, and then utilization of and you'll see MHAD a lot of people will call it MHAD. I tend to call it a mental health advanced directive. And the reason I do that is because acronyms can become a word and people forget what the acronym stands for. So, and if you are asking someone who is looking like they may be going into crisis, if they have an MHAD, they may not know what that means. So the other part of it was program testing and data collection on training toolkits. And then our goal was to report our findings and recommendations to the legislature and the governor by December 1st of 2025, and that happens. So here was some input that we thought about in the beginning. So we really tried to take a look at what was the purpose of the toolkit. What would it look like? We decided it would have to have centralized resources for education and implementation. We thought about, maybe some 2 to 3 one-pagers, we call them one-pagers, or 2 to 3 short videos, and well, that should have been 5 to 7 adaptable full-length training. I will edit that out. 507 is crazy. oh, try to do too many things at once. The other part was content development, any gaps that we noticed. So we reviewed national and local resources and tried to find the gaps for the mental health advance directive. And then we stressed the need for it had to be culturally responsive. It had to be accessible. It had to be something that was usable and that could be tailored to the person. So training for the diverse groups was very important. Who were we going to be aiming this at? As a person who's been an ombuds and working in the grievance system for many years, one of the main issues that I've heard over time and has come to me is, and many of us, that the agency or the facility is not honoring a mental health advance directive. This is probably through not knowing what it is, not knowing how it can help. But we really thought that that would be an important entity, clinicians also. And then the crisis responders. And so these were things that we thought, these are going to be our target audiences. And then we decided that the features would include maybe some role play demos, do some storytelling, maybe some sample forms. But it was important that it be in plain language and that it have multilingual options and also ethical guidelines for facilitators. And the reason we said that is because there could be, we want to make sure that there's no reason to doubt that somebody's going to be totally neutral, that it was important that you might have a potential conflict of interest. So the other part of that, then we're looking at the barriers. So we emphasize the need to address the stigma of a mental illness or behavioral health condition. There are also legal ambiguities that could maybe come into play for somebody using a mental health advance directive, and there was staff turnover that would be at a facility, say one person at the evaluation and treatment center, or the peer respite, or the wherever they were, might have a good handle on it and understand it, and then that person leaves and a new person comes in, and then that person doesn't know what it is and makes other decisions or tries to make other decisions that aren't going to be helpful. We thought that the facilitation of mental health advance directives with peers could be recognized and valued, but then some of us raised concerns about the potential, and I was one of them, conflict of interest and the need for neutral facilitation. For example, our thought was, if you're a peer support counselor and you are also for an agency and you're also helping a person with their mental health advance directive, and you happen to know some things about what's going on with them, you want to make sure that that person is not going to interject any of their thoughts or opinions in what the person is recording. And when we get to the form, I'll show you what we were talking about. And I'm going to try and make sure that I'm mindful of time. But also implementation challenges that we knew that there was going to be, for example, inconsistent form access. There are some old forms that are still being used that were notarized or witnessed. We also knew that there was going to be provider noncompliance. And we also knew that there was going to be the need for plain talk reading levels. Again, it had to have readability. So we met over the course of 2025, and the recommendations report and the trainings were developed within our subgroups. And so the other one was the document storage subgroup. And so we each drafted our respective documents during work sessions, and we were encouraged to review documents and develop recommendations independently. But we also met, we would cross over and go to the other groups' meetings, which I often did. My main concern was making sure that the mental health advance directive form itself would stay and have the integrity that it was needed to have. It wouldn't be too shortened in order to fit certain fields in, say, electronic record system, so that the fields would be able to contain the person's thoughts, wishes, and needs. And there were over 50 of us. We were from everywhere. And I'm really cool. It's really great too. And I should say Health Management Associates is the one who facilitated, and I neglected to call them out in this workshop, so I will update that. But I think it's really cool too that they also made sure to reach out to the tribal 988 and Behavioral Health Advisory Board. And that we also knew that successful implementation would need ongoing collaboration, community-led education, and definitely a phased approach that centers equity and continuous improvement. So, and I want to say too that we, and it's not on one of these slides, but we also, the training work group had 2 pilot sites. One was the clubhouse on the west side, and then the other one was an outpatient provider that also had inpatient facility there, and they used some of the training toolkits that we had that to see of how it would work to have staff or have someone talk to somebody, a person, about what a mental health advance directive is, and if they want to have one or create one. And that was, and then we took a look at that and kind of tweaked some recommendations because of that. But there were 4 main strategies that we came up with. And sorry about that. That was my little speaker that was turning off. So it was very important to have trust and engagement. So it's really important that the person has control over their own mental health advance directive. And they also have to know who can access it and what about it is being shared, because there's some very private and personal information that gets contained in there. And also it's important to have education of the provider community and other community partners, so that we can increase the trust and utilization. Another big piece of that is access and privacy and security. It should prioritize equitable access for diverse populations and easy and quick access while maintaining that privacy and security, including role-based, who has it in their role to be able to access the mental health advance directive. Because it does contain some personal, some pretty personal health information. A big piece of that too is interoperability. I'm not saying this very well. Interoperability and enterprise strategy. So having a single unified repository, and we were talking about possibly the 988 system would have access to it, but there are some systems in place that are being developed that could be easily used as a repository, but it needs to make sure that it has its integrity, but also that the information is accessible when it's needed. And then the other part of this, and I don't know that it has happened yet, but pilot a repository focused on essential features, making sure to improve as it grows. And it's so important to maintain a person-centered approach to the design of it. So we identified 7 next steps that was very important. So align cross-agency efforts. And a central repository needs to be able to integrate multiple types of advanced planning directives. So we know about, I think it's called POST, physician orders on something, anyway, POLST, or the healthcare advanced directive for what you do at end of life, and some other kinds of pieces of information, power of attorney. It's interesting to note that in the mental health advanced directive, you can name an agent, and when I can show you the form, you can name an agent who then becomes your power of attorney for behavioral health care. A regular power of attorney doesn't have that ability, but the mental health advanced directive does designate someone who can consent to treatment, who can consent to sharing records or to not share records, who has to be that person. So also we have to define the system requirements. What is the technical and functional requirements? And of course, knowing that where our budget gaps are, leverage existing technologies and those gaps. And it's important too to determine cost estimates. I'm not privy to that, but I can imagine that there are a lot of costs associated with it. But develop the training and engagement plan. And I will tell you, and at the end of this or later, I will send the link to the Healthcare Authority's webpage for mental health advanced directives. It has a number of our slideshows that we developed, our training focuses. There's one that's called Mental Health Advanced Directive, or MHAD 101. There's one for family members. There's one for crisis responders. I think that is, it's just in a couple of videos that were created about how to talk to someone about creating a mental health advance directive. So just an overview, what a mental health advance directive is. Am I going too fast? I'm trying to make sure that we stay within time. It's a legal tool. A lot of people don't understand this, but it is a legal tool that helps individuals with mental or behavioral health conditions to document their treatment preferences before a crisis occurs or the next crisis occurs. People who've been through a mental health crisis and who have been hospitalized, there is trauma that's associated with that. And there are many things that they know that could have happened differently. And perhaps the treatment team also knows that things could have happened differently. So the mental health advance directive is a way to write down what medications work, what medications don't work, who you can talk to, what are some conditions that need to be made aware of. For example, you'll often hear me say that you can include, I'm hard of hearing. So if you're talking to me, make sure that I'm looking at you so that I can understand what you're saying. It helps me better. If you talk behind me, it's not that I'm ignoring you, I just can't hear you. And those are things that people don't always know. It helps the support teams and clinical doctors and others to understand what the person wants, and also if there are hospitalization consents. And it can appoint an agent to help the person manage their care. And the guide of care, if a person has a mental health crisis and loses their capacity and can no longer make informed decisions about their care. And I think that that's the end of this slideshow, so I'm sorry that it is too short perhaps, but the other thing I want to do is just briefly share the, get rid of this. Briefly share what the form looks like. And then I am so happy to talk to anybody about what it is, what it looks like, and more detail. And so let me just share what the form looks like. Here it is. Okay. So this is it, plain and simple, mental health advance directive. My name is, my date of birth is. If there's any pieces of this that I could recommend that would be changed on this form, would be to include preferred pronouns and preferred name. Sometimes often people who are transgender haven't had their name legally changed yet, but their legal name is considered their dead name. And you have to have your legal name on your document, but also it should have a spot for, please call me this. And so here it is. This is pretty simple language. When does it start? Now, only if I can't make decisions. When's the end date? It automatically ends or remain in effect until it's revoked. And it's important to note too that you can revoke the mental health advance directives, and this is a spot where you can do that. My care needs, here's the best treatment method for my illness. I take these medications. I have a history of drug or alcohol abuse. Here are my preferences and instructions. Here's my medications. I do not consent to these. I consent to these. I will try other medications for mental health treatment. Or I don't want to try. And these are that person's choices. And I think that they also need to be followed. So I want these interventions before psychiatric hospitalization is concerned. Connect me with a peer counselor as an example. Check one sign of consenting. I consent to voluntary admission. I do not consent to inpatient mental health treatments. Here you have an opportunity to perhaps spell out what hospital you prefer to go to, although we know that that's not always going to be an option. Here's my options about seclusion, restraint, and emergency medications, if that becomes necessary. And if it's required, please follow my preferences in section 6. And here's a piece about ECT and excluded visitors. I mean, they often ask you who can visit and who can't. Here is the part I talked about. Am I going too fast? I don't know. Durable power of attorney for mental health care. This is optional. You don't have to name a person. But if you are, this is where you put it. And this person is then that one who can come in and help make those decisions and can even sign release of information. And I authorize my healthcare providers to release all information and accountability to my agent, and this is very important. I'm going to stop sharing here, and I'm going to say one of the reasons why that is super important is because we all know that, maybe we don't all know, but release of information is often time limited. But a mental health advance directive is not. And so if you're hospitalized, say in March of 2026, then you're hospitalized again in January of 2027. If you were at the same facility, that facility where you're at may have had you sign a release of information, but was only good until you were done with your hospitalization. So the next time you get hospitalized, your agent may be denied access to you because you don't have a current ROI. And that is a barrier. And I have had people contact me who were the agent and who were denied ability to talk to their person because they didn't have an ROI. And it's understandable that professionals do not want to risk their license. The fines can be huge and implications for treatment, but it's a very important piece of this. And that's one of the reasons that I always like to emphasize that. So I think I stayed to my scheduled time. And are there any questions?
Gail, thank you very much. So I know you mentioned that there are 7 next steps. I guess what would be some of the most immediate, and I guess when will there be sort of updates that we might be able to hear or see or find out about? And then my second kind of question, I guess, is I noticed the website, the WashingtonLawHelp.org was that where the document came from? Is that correct, or where it's posted?
It was updated in March of 2025, the one that I showed. I think the Healthcare Authority Mental Health Advance Direct MHAD website still has one that's from 2024 in their link. I think it's important to use the most recent one. I like this form, it's fillable, and it includes the elements that I think are important, such as, okay, I'm gonna get better. I want to get better, but I can't if I don't know who's taking care of my cat. I can't if I don't be able to tell my boss I'm not going to be at work tomorrow. I can't concentrate on getting better unless these other things happen, or please go get my mail, because people will know that I'm not home if my mail piles up. Those things, but that's things that the agent can talk about. The agent can handle that. So. But yeah, I think the repository is going to be a very critical next step. But the other piece of it is the community education, the training, the provider training, the understanding of what it is, what a great tool it is, what it can be and what it can't be. And so, again, anyone who would like more detailed information about a mental health advance directive, please reach out. I'm happy to do that. I have a 3-part presentation I use that talks about why you want to have one, what's things to consider. And I know that Chantel knows about that one because I presented it at NAMI and some other places. So that's it. Any other questions? Thank you.
No, Gail, thank you very much. Very, very useful. Okay, taking a look at our agenda and moving on. Oh, before we do that, I note that Nisi logged on just a tad bit late. Nisi, I understand that you're having difficulty with your voice, so you may or may not want to speak. You're certainly free to, but I do want to acknowledge that you are here. So welcome, and thank you for coming.
Thank you so much.
All right, let's go ahead and move on to administrative updates. Ashley.
Good afternoon, everyone. Thank you for that great information, Gail. Very helpful. I know a lot of work has gone on with that and will likely continue as the state looks towards many different changes and implementations that they're doing. One of the first things I did want to provide an update on is the 988 hub designation. So I believe the last time we spoke, or the last time we had a BHAB meeting, the Department of Health, who oversees the 988 system in Washington State, was going through their procurement process for hub designation. As you all know, Frontier Behavioral Health is the current 988 provider for the Spokane region. And they did apply through that hub designation. And towards the end of January, or not January, December, right before January, we were notified of that selection, and Frontier was selected for the Spokane region to maintain the 988 hub for our region, which is something that, you know, we already have in place and supports kind of the vertical integration that we have with Frontier Behavioral Health. There were some changes across the state regarding who those 988 hubs were, and there was an addition of a fourth hub provider. This Thursday, we actually have Katie Lindstrom, and that's maybe something we can also look at for the future BHAB meetings, presenting on kind of that 988 hub designation process. As it stands now, all 988 providers who are currently providing the contact center services are contracted through June 30th of 2025, with the new hubs coming online in July, depending on readiness. And that's kind of the stage that the Department of Health is in currently, is going through their readiness reviews and contracting with those 988 providers who were selected. So at this point in time, no major changes anticipated. The one thing about the Spokane region, because we have vertical integration with Frontier Behavioral Health, who's also our regional crisis line provider covering our 6 counties, and our 988 provider covering our regional service area, as well as doing backup to other counties across the state, is that we've been able to kind of initiate that transition plan, which we've talked about here, develop a mobile dispatch unit. So there's a streamlined approach for mobile response for once those calls are determined to need an in-person response, to get those out to the teams to be able to respond in the field. We'll also freeing up those lines for individuals calling in that maybe just need that phone contact and support. And so we continue to have the 988 number for individuals to call. We continue to have the RCL number for individuals to call. And our MDU mobile dispatch unit is working with local providers to kind of create that entry door for direct referral once it's determined through law enforcement or hospitals, things like that, that a mobile response is needed or a DCR is needed. So I wanted to provide that important update just because as we look towards the future, I'm sure more things will come from that hub designation and we might learn more. And I'll go ahead and pause here to see if there's any questions related to that. Not seeing or hearing any. Wonderful. The next thing I wanted to discuss today is legislative updates. As many of you know, we are in the legislative season and cycle, and we are here at the ASO trying to keep up with all the bills. I will note that there's quite a few different bills that have carried over from the previous legislative session that didn't end up going anywhere, but are still kind of active. We're keeping our eye on those to see if they proceed forward or not. But there's just kind of a few bills that some I just wanted to mention that we don't have, you know, very detailed information on yet, and some that we have a little bit more information on and will be tracking through this legislative session. One of the first ones, something to note, there's quite a few bills related to ITA and Voluntary Treatment Act laws and RCW 7105 and 7134. Some of those are bills that carried over from the last legislative session, and some of those are newly introduced. One of those carryovers is House Bill 1905, and this bill is concerning appointed counsel for individuals detained under the Involuntary Treatment Act, and it clarifies the right for individuals detained under the ITA Act, their right to counsel, and assigns responsibility for appointed counsel to the county where the person is detained, not necessarily the county of residence. And it overrides local rules and standardized reimbursement. Part of this is important to note because recently with our ITA system, there has been some notification of different processes across the state when it comes to prosecution, I guess, and not necessarily noting that this will resolve that issue, but something that we're currently working to navigate, but hasn't had much impact on the Spokane region. And that's that in King County, their prosecutors due to a certain provision in the statute, are not representing individuals who are sent to King County on LRA revocations, so a least restrictive alternative, someone who has transitioned from inpatient hospitalization to the community and has certain conditions that they follow to support their treatment in the community, but are still under an involuntary commitment on an outpatient basis. At times, those individuals may need inpatient hospitalization and their LRAs are revoked in their return to inpatient care. And if those individuals are transported to King County before that first initial 5 days after that revocation is made, then the county from which that individual came from has the option to represent them, or the courts are also looking into, possibly looking at an initial detention instead of a revocation. So this creates some logistical challenges, and from the Spokane perspective, we want to ensure that the individual's care is coordinated and that we don't lose any supportive nature that the LRA may provide to an individual when released back to the community. It's important to note that this has not been we have not had any cases come up as related to this in the Spokane Regional Service area, but just something that we are tracking. So important to note as it pertains to this bill. It also updates and harmonizes definitions in RCW 7105 for adults and 7134 for minors, resolving some conflicting amendments from 2024, and really clarifies the roles of the county prosecutors versus the attorney generals in the ITA proceedings. The next one I'll mention here is, sorry, my screen is a little too big, so I'm trying to make it bigger here. Is we have a Senate bill and a House bill, both pertaining to ensuring transparency in credentials and communication between patients and healthcare professionals. And that's House Bill 2261 and Senate Bill 6166. And this would require healthcare professionals who provide behavioral healthcare services to wear an identification badge with their name, credential, educational information during patient encounters, and prohibits persons from representing themselves as either an osteopathic physician surgeon or physician surgeon unless they have met specific requirements to licensure. So essentially, this would change the badging of a lot of our behavioral health agencies and what would be required to be on that badging as individuals interact with individuals receiving behavioral health treatment services. So something in healthcare services, something to note here. We are also tracking bills related to licensure. There's a couple different bills related to social work licensure and kind of governance boards of different licensed roles within the behavioral health sphere. I won't get too much into the nit and grit of those bills. There are two bills that kind of interact with each other, House Bill 2302 and House Bill, apologies. I might not have this on my list here, but I can get that to the group here. But it's concerning expanding prescriptive authority to pharmacists. So there's two bills that kind of incorporate pharmacists, expanding their scope to allow them to have kind of a little bit more intersection in the behavioral health field when it comes to a credentialed provider being able to make some determinations and assist in those determinations and treatment during involuntary treatment, as well as kind of the initiation of involuntary treatment, kind of expanding that scope. And so those are a few that are interesting that we're tracking, and I'll get that second one to you guys once I can find that, hopefully before the end of the meeting here today. There's also another bill concerning the Involuntary Treatment Act, and this is 2383. This one has some particularly interesting changes. This would extend the initial involuntary detention time period. Currently, that's 120 hours, not including weekends and holidays, and that would extend it to 168 hours, which is essentially 7 days. And that is a change. It used to be 72 hours, then it was changed to 120 hours, and now this bill is looking at 168 hours for that initial detention. and would also increase the kind of the inpatient commitment period from 14 to 21 days. It would align all related timelines in the statutes to that 160 hours. Currently, if an individual is brought into an emergency room or an evaluation and treatment center, a 23-hour crisis relief center by law enforcement, there's a 12-hour time period for evaluation, and that would extend that 12 hours to 120 hours, which is also an interesting change in there. So we are tracking that one pretty closely. There's also some incorporation of the new facility type, the 23-hour crisis relief, which Justin spoke on and provided a presentation on last time we met, for that kind of involuntary detention until an evaluation can occur. So I just thought I'd mention that one. There is one more pertaining to ITA, and that is Senate Bill 6296 concerning involuntary treatment. And this does a few different things as well. It would ensure that the courts must review criminal history prior to civil commitments, pending proceedings, and firearm CPL history before issuing involuntary treatment orders. It would clarify representation, such as county prosecutor representing in most commitment matters, and the attorney generals representing at state hospitals and facilities, which is currently the case. And then venue-specific representation clarified for the LRA modifications and revocations. So again, speaking to recent changes as it pertains to LRA revocations in other municipalities or other counties. It would lower the standard for assisted outpatient treatment petitions to preponderance of the evidence from clear, cogent, and convincing, which it currently is now. It would retain core criteria, but expand and clarify qualifying history for assisted outpatient treatment. There's quite a few different changes to the assisted outpatient treatment component of the statute, RCW 7104 or 05148. And it would give some clearer timelines for hearings as it pertains to that, and also incorporate kind of that mandatory notification for tribal healthcare providers within 24 hours when an individual who is identified as American Indian or Alaskan Native, to ensure that the tribe has information and they have the right to intervene and receive orders or any hearings related to involuntary treatment. So quite a few different changes proposed with the ITA bills. Some other bills that we're tracking have to do about referencing emergency medical transport, which continues to be something that is a challenge statewide, but definitely in our region, getting EMS services to transport individuals across the state, and then also having individuals be able to be transported back in a safe and timely manner. And so there's some bills that are related to that. And then the last one that I'll mention here as well is there's a bill related to Maddie's Place, who has come and spoken at the Behavioral Health Advisory Board previously. Spokane County does fund services through Maddie's Place, who's a pediatric transitional care facility here in Spokane, Washington, one of 4 in the nation, providing this treatment service for infants impacted by neonatal abstinence syndrome. There is House Bill 2560 and Senate Bill 6094, and that is concerning facilities licensed to provide pediatric transitional care services. And this would require the healthcare authority within their existing resources to submit a state plan amendment for residential pediatric recovery centers as a Medicaid benefit. Currently, it is not. This would allow for Maddie's Place to have a sustained billing practice for the services that they provide. Currently, those aren't approved in our state plan. And so this would have HCA update that state plan amendment, or amend that state plan to allow for billing under Medicaid, as well as provide some grant funds subject to appropriations for certain facilities until that state plan amendment is approved. And it would direct the Department of Children, Youth, and Families in coordination with HCA to develop and implement a non-medical bundled payment, which is subjected to appropriation for maternal and child health programmatic services provided by residential pediatric recovery centers to infants born substance exposed and their families. And then make some changes to the requirements for facilities providing care under pediatric transitional care facilities. Kind of pause here. I know that's always a lot of information to go through, and that's probably not even half of it. Obviously, we'll continue to come back as the legislative session progresses with updates with what has moved forward and what has kind of not moved forward. A lot of different things to track this legislative session, and it's pretty quick. But I'll pause here to see if there's any questions, comments, or anything else that individuals are tracking or keeping their eyes on here.
I have a question, Ashley. Can you tell me, and this has to do back with the extension of the detention time from 120 hours to 168 hours? Do we know what is behind that?
You know, anything I would say would be conjecture at this point, Gail. I do know that there has been challenges at times when individuals are on that initial 120-hour detention and maybe there's a bed available across the state, and being able to have the court proceedings in a timely manner to ensure that that individual kind of has due process associated with their treatment, and their involuntary commitment status. That has been a barrier in getting individuals out of maybe a hospital on a single bed certification into an inpatient treatment facility. There's also a lot of challenges with court staffing right now. That's also something that the state's experiencing quite heavily. But I'm not really sure what the onus is of this change. And I don't believe they've dropped the bill digest yet to kind of give a little bit more background. But I'm curious on that as well.
Yeah, I've kind of been checking into it periodically, but I haven't looked at it recently. So just wondering if there've been any more updates on that.
Ashley, thank you very much.
Yeah, absolutely. I got just a few more crisis updates here, and then I'll turn it back to you, Kim. Just some crisis system updates I wanted to touch base on. One is facilities, because we do anticipate some potential new facilities coming online, maybe 1 or 2 within our region, and then some later, maybe in some closer regions, which are impactful. So one of the first things I wanted to just briefly discuss is secure withdrawal management and stabilization services, which is also known as a SWIMS facility, SW. I'm not going to spell it out because I will mess it up here. But that is for secure withdrawal management services for individuals who might be detained under Involuntary Treatment Act under a substance use disorder. Also known as Ricky's Law, which passed back in 2018. For Spokane, this is utilized within our regional service area. I believe within the last 12 months, we had 288 individuals detained to SWIMS facilities. And for the non-Medicaid portion that the Spokane County BHASO covers, that's about 68 of those individuals. There's 3 facilities across the state that provide this level of care. That is Lifeline Connections on the west side, Valley Cities in King County, and ABHS Chehalis, which is in Lewis County, all on the west side of the state. ABHS Chehalis is the closest, and that is the one that is most utilized of those 288 detentions. The majority, I believe 65% of those individuals went to that facility. We used to have ABHS Parkside located in Wenatchee, but last year around February 14th, that SWIMS facility closed. And this is all to identify that we anticipate a new SWIMS facility coming online on the east side of the state, which is impactful for our region. Also because if an individual is found to meet detention criteria under this provision, if there's not a bed for them to go, then they cannot be detained. There's no single bed certification process for any of this. And so, that becomes challenging when trying to determine how to care for that individual in maybe a more imminent situation. But Comprehensive is a treatment provider in Benton County and Benton Franklin County. They're working to open Columbia Valley Wellness Center, which will have 4 different levels of care. And this is an old hospital that was purchased down in that region, and they've been under construction to make 4 levels of care, one of those being a crisis relief center, which is what Justin kind of presented on the last time at our Behavioral Health Advisory Board meeting. Also a crisis stabilization unit, which is also what we have at the current Spokane Regional Stabilization Center for Mental Health Stabilization. A SWIMS facility, so that's Secure Withdrawal Management Facility, and an evaluation and treatment center, all within this area. And they do anticipate doing a phased opening starting this spring of those different service levels. And so we do anticipate some closer resources for some of those more challenging resources we don't have on the east side of the state. So an important update there.
Do you know how many beds that Columbia would have total, or the breakdown of the bed space for?
I think
The 4 levels.
16 in each unit, but that might differ with the CSU and the crisis relief. But I think for ENT,
Got it.
it's 16.
Got it.
And as Justin talked about, our Crisis Relief and Sobering Center, we still are on track for that to open in spring of 2027. Construction will be starting here soon, so that will be exciting. We'll continue to come back and bring you guys updates on that as we move along in that process. And then also Multi-Care did receive a Department of Commerce grant within the last couple of years to build out an inpatient psychiatric unit within their Deaconess South location. The last update we heard is that is anticipated to potentially be open and available in the last quarter of 2025, so sometime in the fall, early winter, but hoping to get more information and be able to bring that to this group here. So plays into kind of resource availability within our regional service area. Important to note what might be coming. I'll pause here on the facilities kind of side of it before I cover one last component here to see if there's any questions or input from our group here.
These beds are much needed.
Absolutely. And so more to come on that in the future. The last thing I wanted to just touch on quickly, and Arlia, do you mind if I share my screen real quick, please? Thank you. The state, as we kind of talked earlier about 988 RCL, and I know we've talked in this space about kind of that transition to streamline those services and have a centralized number for individuals to call seeking service and a centralized number for professionals to call seeking kind of that mobile response and streamlining that system. The state has been looking to, share here, there it is. The state has been looking to kind of streamline and make a consistent process across the state of how that will go in each regional service area. And so they've developed what is called a crisis care acuity guide. And so again, trying to align regions and responses across the state, which can differ greatly depending on individuals' location, resources availability, and practices. But we do have our local crisis provider here in Spokane County. Frontier Behavioral Health will be participating in a pilot program with the state on utilization of this acuity guide. This is just kind of a quick glance. As you can see, it is in draft form for individuals and really the mobile dispatch unit to be able to utilize when determining who would make the most appropriate sense to send out on a case. As you'll see here, there's different levels of response identified, with level 1 being no dispatch is needed, but some specific caveats that play into the services that we offer within our regional service area. One of those being our child, youth, and family mobile crisis team that provides services under mobile response and stabilization service model, the MRSS model, which means if a youth or family calls, always offering that outreach because we know that can help be an upstream intervention for that youth and family. We've got level 2, which is an urgent risk, requires scheduling a response within 24 hours. We have a level 3, which is an emergent risk, requires a response within 2 hours or less. Level 4, which is a behavioral health emergency requiring a response of 1 hour or less. And level 5 would be a first responder response requiring an active rescue response. As you see, there's some notes on the bottom here. They're really being very intentional with this tool, ensuring that taking into consideration all different components of what that might look like. If an individual is a tribal member, ensuring that they're utilizing the appropriate tribal resources, such as the tribal crisis coordination plans, and following those, as well as getting involved Indian healthcare providers if known and accessible. If individuals have an intellectual or developmental disability, some guidance on there as well. And then youth, how do we engage with youth and ensuring that we're providing kind of that upstream intervention? Again, this is kind of the quick glance guide. They've got a whole guide that accompanies that. And that's something that I just wanted to make note of, that one of our providers for the next 6 months will be participating kind of in a pilot study to work to improve this guide and kind of see how it operates in action and see where we can help streamline that approach. Important to note that because Frontier Behavioral Health in our region is vertically integrated, I think we're kind of ahead of the game in what will come with some of the 988 hub designation here in the July period. And so excited to see where that leads us. And I'll pause here for any questions. And if no questions, turn it back over to you, Kim.
Okay. Folks, any questions for Ashley? Okay, let's move on. Let's see, we're going to come up on consumer consultation panel with Tom. I would just like to comment that in December, I had an interaction with Santa Claus, who I find looked quite a lot like Tom Gose. I just want to add that. And I think, Gail, that was your experience as well?
Yes, it was. And I had my picture taken with that Santa Claus.
Me as well, yes. Go ahead, Tom. All yours.
Well, I have here my CCP minutes from November and December. First I'll do November. At this meeting, our guests were Kaylin Roy, a liaison between the VHO, ASO, and CCP, and Gail Kogel of the Behavioral Health Advocacy. Brent Smith, CCP chair, facilitated the meeting. Also attending was Robin Sagner, CCP co-chair, Tom Gose, CCP secretary, and CCP members Aaron Smith, Sarah Leak, and Rose Plorty. Sophia Alexander was absent. The online November 2025 CCP meeting was called to order. The October 2025 CCP minutes were read and approved. There was no October Behavioral Health Advisory Board meeting, so this was not reported on. We discussed the coming CCP Santa Picture event. This will be held at Audubon Methodist Church at Driscoll and Garland on Saturday, December 6, 2025 from 1 to 3 p.m. CCP members should arrive by 11 a.m. It was mentioned that we should tell the people who have their picture taken with Santa that they can make big copies of the photos at Walmart rather cheaply. It was noted that if 100 people can have their picture taken, the CCP can buy new CCP t-shirts, or instead of the t-shirts, the CCP can buy a t-shirt making machine. Pictures only cost $5. Kaylin said they had sent out an email about the event to everyone in the system of care. Brent said that the CCP members were invited to come to Audubon Methodist Church on Wednesday, December 3rd at 12 noon to pass out flyers around the church neighborhood to advertise for the event. We discussed the CC budget for 2026. Brent recommended that $250 be provided for the Jaunt in June when a walk-in event put on the CCP. This will cover prizes, water, snacks, poster boards, and materials for sign. It was suggested we cancel buying balloons this year. Instead, we should buy nicer prizes. It was also recommended that $50 be provided for the CCP attendance at Evergreen Club Fun Run. It was mentioned that the CCP can have a table with the Hands Across the Bridge event for free. It was also mentioned that we may be able to use the money made at the Santa event for next year's Santa event. Next CCP meeting will be held online or in person at the OBHC building on Monday, December 8th, 2025 from noon to 1 p.m. If possible, the CCP members who attend in person should bring snacks for the Christmas party. Meeting was adjourned. And here's my minutes from December. At this meeting, our guests were Kaylin Roy, liaison on the BHSO and CCP, and Gail Cole of Office of Behavioral Advocacy. Brent Smith, CCP chair facilitated the meeting. Also attended was Robin Stegner, CCP co-chair, Tom Goes, CCP secretary, and CCP members Aaron Smith, Sarah Leek, and Rose Plorty. Sophia Alexander had an excused absence. The online December 2025 CCP meeting is called to order. The November 25 CCP minutes were read and approved. Discussed the November Behavioral Health Advisory Board meeting. At this meeting, a new board member was introduced, Kenny Carlson. He learned about the BHAB from Sean Lindsley. Kenny has been sober a number of years. He wants to help others navigate and overcome the problems of addiction, incarceration, and homelessness. He is now with a nonprofit that helps with this. There was a SCRBH ASO update on the new Crisis Relief and Sobriety Center by Justin Johnson. The plan is being designed to provide immediate service and jail intervention. There has been a need for immediate walk-in services. The center is trying to limit costs yet still provide care. 2 years ago, a state passed the 23-hour, 59-minute limit of stay for such facilities. The center will be voluntary, not involuntary. This facility will be ready by spring of 2027. There will be 24 chairs in the center, and the center can provide medical evaluation and medication management. The center will be located on Boone and Cedar near the jail. There was then a crisis relief data dashboard update by Amy Fair. This time there are 388 high utilizers, 7,426 regional crisis hotline calls, 4,710 individuals served, and 19,567 total services provided. Also at this meeting, there was a jail transition and diversion team update by Jessica Thompson. She said the community services diversion team tries to reduce criminal justice for citizens. The team tries to provide connection to services. They try to connect participants to secure, stable housing and improve their quality of life. Clients are eligible if they have BH challenges and classified as committing misdemeanor. 70% complete the program and 89% of do not reoffend for 12 months following the program. Clients are referred by BH providers in the detention service. There was then an SCRBH update by Ashley McGee. She said that at this time there was nothing new. House Bill 1813 was mentioned. The bill will provide information on BH crises across the state. SCRBH ASO will oversee the system. The CCB then a recap of the CCB Santa Picture event. The event was good financially. This year we took in $55. Last year we took in $45. The CCB has $100 in the CCB fund. Rose and Aaron thought the pictures went well. Rose said that we should include animals in the pictures and buy animal treats and bring animal treats. Brent said that once things got going, the event was relaxing and that he bought a printer the day before. The CCB reviewed the 2026 budget. We suggest that we use $300 for the Jaunt in June, a walk-in event put on the CCB, $150 for new CCB t-shirts, along with this $100 in the CCB fund, and $50 for CCB attendance Evergreen Club fun run. Some other items mentioned were that we should give a thank you card to the church where we had the Santa event, the Audubon Methodist, and that if possible, the price of Santa pictures should remain the same, $5. Brent said that the price of a box of candy canes went from $1.50 to $3, but that we still have photo paper and frames for next year. Also, Robin said she would put a thank you notice on the CCB Facebook page pertaining to the Santa event. It was suggested that Gail upload one of her Santa pictures for the CCB Facebook page. Next CCP meeting will be held online or in person at the OBHA building on Monday, January 12th, 2026 from noon to 1 p.m. Meeting was adjourned. Those are my minutes.
Tom, thank you. Any questions, folks, for Tom? All right, let's move on with the agenda. It is this time of the year again that both Shane and I, in theory, will step down, and in the spirit of, again, cooperation and sharing, both of us would like to invite some of you to consider being chair and or chair or vice chair for this upcoming year. So are there any folks who would like to throw their names in, or any folks who would like to nominate someone else to take over duties for the year? Don't be shy, folks. Don't make me start calling names here.
This is Karina Love. If I got a little bit more details about it and what it entails, I would like to check it out and possibly go for it.
Yeah. Feel free to ask specific questions, but in general, the duties are similar, pretty much to what I've done today. So take charge of either chairing the meeting, similar to, again, what I've done over the last year or so. The vice chair, for all intents and purposes, steps in doing so when the chair is unable to do so. So that's very much the very short version of responsibilities.
Yeah, I would be interested.
Beautiful. So Karina, anyone else would like to consider chair or vice chair? Karina, did you have a preference for which position you would like?
No, either one.
Okay. Anyone else? Okay. How about this, Karina? We can either vote you as chair, or I will continue as chair for another year, making specific effort to have you chair some of the meetings while I'm present, instead of doing so just in my absence, if you would like to do that. So tell me which of those you are most comfortable with.
I would like to kind of have a soft handoff, like vote, have you as chair, and then I could do some with you as presence until I got a little bit more familiar with it.
Okay, that sounds fine. So, if you will, motion on the table, if someone could propose this.
I'm gonna motion her as assistant chair. How's that? And I'll step down in the spirit of rotation.
Fair enough. Do I have a second to that?
I'll
Second.
Perfect. Just as a separate motion, and vote, is there a motion for me to continue as chair for this coming year, with the plan for Karina to take over the following year, potentially?
I'll make that motion, Kim.
Okay. And the second?
I'll second it.
Okay, perfect. Okay, so to summarize, I will continue as chair for 2026. Karina will serve as vice chair. During 2026, I will specifically have Karina chair some of the meetings, so she has experience in doing so, with the goal ultimately that she will take over as chair for the following year, even though she certainly can turn that down. But it doesn't have to be necessarily a set expectation, but maybe an ideal off the record expectation or goal. Any questions or comments about that? Okay. In the absence of hearing none, thank you all for coming today. Looks like our next meeting, sorry, I missed the public comments part. Any final comments or statements for the good of the group?
This is Lita speaking, and I might be interested in a position in the future, but not at this moment. I also have someone who is interested in being a part of this committee and has extensive peer experience, and so I'll be talking to her in the near future.
Okay, that sounds great. Thank you. Any other comments before we adjourn?
Kim, I believe we had a second, but I don't know, did we actually have a vote?
Thank you. Appreciate that. Go ahead. I'm sorry.
Details.
Yeah, your details, exactly. Okay, let's go through the process again. Can we have a motion? And Michael, you're going back to the chair vote, correct?
Right. I think we had a motion and a second on both, for you to stay as the chair and Karina to be the vice chair. And I think we
need the vote.
do a
Okay.
separate vote on each one. It's going to be
Fair
quick.
enough.
I think it's just
Fair enough.
formality. Yeah.
Okay. For Karina's vice chair, can we have a vote? All in favor, please?
Aye.
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 Okay. Any opposed or abstaining?
Nay.
Okay, fair enough. Thank you. Vote for me continuing as chair. All in favor, say aye.
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 Thank you. Abstaining or no votes? Okay, perfect. So again, thank you all for being here today. Our next meeting is going to be Monday, March 23rd. I will see you then. In the meantime, Karina, I will be in touch with you and we will talk further. Thank you all. Have a good day. Let's go ahead and
Okay,
have a
thank
motion to
you.
adjourn.
A motion.
Thank you.
Second.
Sounds good. Thank you all. Have a good day.
Thank you. Bye.